Hello, this is your brain on drugs, and this is a punk rock psychiatrist. So, what we're going to go into is the effects of estrogen on ADHD today, and I'm going to also try and hit up a couple of hard to treat um, issues with ADHD at the end, and this is going to wrap up ADHD for this season. So, thank you for joining me for this season, and I just want to put in a quick thing. If you do like the podcast, it would be really helpful to me if you could just rate it. I've got, I don't know, 22 ratings on Spotify and on Apple. And so like the more I can get, the more that other people will find out that it exists. And so if you think it's good, just give it a rating. And real quick, just hit the stars there. But let's go ahead and get started. So, effects of estrogen on ADHD. All right. So, first, let's review the menstrual cycle. So, you've got three phases: follicular phase, luteal phase, and menses. And hormones change during each one of these phases. And what those hormones are can have an impact on symptoms of ADHD, in that if you don't have ADHD, you could get some symptoms during certain times. And if you have ADHD, then those symptoms could get worse, right? So let's talk about those effects, and then we'll talk about what we could do to manage it after that. All right. So we start off, menses is completed, you know, period. It's over. We're starting a new follicular phase. Um, we start off, estrogen begins to rise during the follicular phase, um, and the ADHD symptoms are at their best. So this is, your period is finished, and you're now starting your new cycle. Those first 14-ish days prior to ovulation is your follicular phase. This is typically the most pleasant time during a menstrual cycle from a moods perspective, but also from an ADHD perspective. Right. So we talked about this a little bit in the depression series. So if you want to listen to that and see how these issues can be affected by depression, go ahead and go to the depression season and listen to the episodes here. We're going to be talking mostly about ADHD today. All right. So, follicular phase, your period's finished, estrogen levels are rising, ADHD symptoms are at their lowest. And if you have ADHD, you're the most responsive to taking your ADHD medication. So, it seems like your ADHD symptoms are the most under control, and that would be because they are probably the lowest that they're going to be. All right. So at the end of the follicular phase, we get, jumps in luteal hormone, FSH, ovulation occurs. Once ovulation has occurred, we move into the luteal phase. This is the phase in which you're being prepared for a pregnancy, right? So during this phase, estrogen drops like pretty quickly once ovulation occurs. The levels are go up slightly and down, but they're lower during this phase, and progesterone increases throughout this phase because progesterone is what's preparing you for pregnancy. And if pregnancy doesn't occur, then that's menses, right? So progesterone is increasing, ADHD symptoms are increasing. If you have premenstrual dysphoric disorder, that's when the symptoms of that are at their worst. And if you if you have ADHD, you may notice that these mood symptoms are also worse for somebody that has ADHD versus somebody who doesn't have ADHD. So there's a comorbidity there between ADHD and premenstrual dysphoric disorder, or PMS, as it's been called in the past. Um, and then your medications for your ADHD, you may notice, are less effective during this period of time. Okay. So and then you have menses, estrogen's at its lowest, ADHD symptoms are at their worst. You complete your menses and estrogen starts to go up again. So the pattern here seems to be that you feel better when estrogen levels are higher. Okay. Mood wise and ADHD symptom wise. And then as we get a falling off of estrogen and as we get to the lowest when menstruation occurs, we have the worst outcome there. Okay. So that is generally for people how that would go. Now that's while you're menstruating, right? This is when you're, during your, I don't know, 12 to 50 years old kind of time frame. But then when you're going through perimenopause, which is on average between 45 and 55, right? These hormones don't act the same, right? So we then when you're in your time of your menstruating time, there's much more consistency, and you may notice, oh, I'm doing well during these 2 weeks, and I'm doing less well during these 2 weeks. But then when perimenopause kicks in, these hormones don't go up and down as consistently, right? Generally over time estrogen levels are falling, but they're kind of like jumping up and down throughout this time period. They're kind of just spike and trough, up and down, right? So that's one of the issues during menopause is you get like wild fluctuations in estrogen. The same thing happens when you're first starting to get your period during puberty. Estrogen levels are kind of inconsistently going up and down. In the time in between puberty and perimenopause, estrogen levels kind of go up and down in a predictable manner. And then progesterone, it goes up and then down as well during perimenopause. So as you're going through perimenopause, estrogen and progesterone are both like going down in general, but they're kind of, moving around during that time in unpredictable ways. And then once you've reached menopause, they will be at lower levels than they were before. Okay. So you get this irregular cycle, average age 47. But like I said, it typically ranges between 45 and 55. And perimenopause is this time period where this transition is happening between having the ability to get pregnant and not, and having a period and not having one. That is like this inconsistent period where your hormones are kind of jumping up and down in unpredictable ways, right? And this can last between 4 to 10 years. Okay. And I think a lot of people call this menopause. This is not menopause. Menopause is actually one, it's like one cycle, right? It's like it is the moment it was like your last cycle. Once you went from having a cycle to not having a cycle, that moment in between there, that's menopause, right? The time before that where you're not feeling so well is called perimenopause, which means like around the time of menopause. And then after menopause has occurred, you're in what's called postmenopause. So a lot of people they describe this perimenopause time period to be menopause, but menopause is really just, it means, a pause of menses, right? So it's the moment it stops. Okay. And it says what I have here is 12 months after last cycle. I don't know, that doesn't really jive because I've got moment of final cycle versus 12 months. The thing is, you don't really necessarily know that you had menopause until 12 months later, because like you might have a cycle 3 4 months in. So once it's been 12 months since you've had a cycle, you know that you have had menopause. Menopause was the time at which you stopped having menses. um, the average age for menopause is 51. All right. So I said perimenopause 47. So on average, that's when this irregularity of cycles starts, is around 47. And the average age in which it stops is 51. But there's a range. 45 to 55 is what I generally hear. Some women sooner, some women later, some women might be even sooner than that. Um, and then postmenopause is the time after menopause. And typically, people feel better during that time period. Their hormones have leveled off, right? So what's important when we're talking about, with ADHD is like, while estrogen levels are inconsistent, that can affect your ADHD symptoms. And they're inconsistent during parts of your cycle, and they're inconsistent while you're going through this perimenopause time. And they're also going to be like, you're going to have lower estrogen in this postmenopausal period, as opposed to when you, even before perimenopause, when you were at a time where you're having regular menstrual cycles. compared to once you've completed menopause is over, you're in the postmenopausal time period, your estrogen levels are lower. So many women may notice that ADHD symptoms are worse consistently during that time. Okay, so another important thing to consider is the overlap in menopause symptoms um, and ADHD symptoms. So it's some of them are the same. So just because you're having some of these symptoms, they it doesn't mean that you have ADHD. This could just be symptoms of menopause, right? So let's go ahead and go. I'm going to go through the list of menopause symptoms, and I'm going to highlight which ones of those overlap with ADHD, and then we're going to talk. I'll mention the ADHD symptoms and do the same thing. So you can try and think about differentiating these, which can be difficult. All right. So with menopause, or really perimenopause, right? Hot flashes, night sweats, irregular periods. Okay, sleep problems. Sleep problems is something that you can have with ADHD, so that's an overlapping symptom. Weight gain, mood lability and anxiety, that's another symptom that overlaps with ADHD. Loss of libido, vaginal dryness, impaired attention, concentration, and memory. Also, I mean, that very much overlaps with ADHD. Bone loss, that would be like postmenopause. Depression also, it overlaps with ADHD symptoms. Urinary infections, heart disease, breast cancer risk, those are all things postmenopause. So, as you can see, out of all the menopause symptoms, we've got sleep problems, mood lability, anxiety, impaired attention, concentration, memory, and depression, which could all those are all symptoms of menopause, but they also could be symptoms of ADHD. Okay, so um, they can confuse things a little bit there. So, and now when we look at symptoms of ADHD, I'll try and group these more appropriately. I'll tell you the ones that overlap first, but we've already kind of mentioned them: mood lability, sleep disturbance, work inefficiency, and that could be because of the impaired attention concentration, temper outbursts. So that's mood lability, right? As well, depression, inattention, but then some symptoms of ADHD that uh, we don't really see with menopause. We procrastination, impulsivity, hyperkinesis, which is like restlessness, financial impulsivity. So it's like I mean, most of the symptoms of ADHD are similar to the symptoms of menopause. So it's also important here to kind of think of timing factors of like, when did these happen? All right. So if you have ADHD and then you're going through menopause and you notice your ADHD symptoms are getting worse, it may not be that it's connected to your ADHD. It may be connected to the menopause. Okay. So this is important because it's like, how do we treat this? Are we treating, are we going to increase ADHD meds? Because this is ADHD is worsening, or do we add hormone replacement because this is a menopause issue, right? And which one would we do first? And so that's important to consider. All right. So also, we talked about the luteal phase. So that's the phase from ovulation until menses. Um, a lot of things get worse, not just ADHD. And we already talked about depression, anxiety, kind of mood stuff, but also bipolar disorder can get worse during that time, but also some non mental health issues, migraines, asthma, diabetes, epilepsy. There's a connection between kind of worsening symptoms during luteal phase for a lot of disorders. And if you have some of these disorders, you may notice, oh yeah, my migraines are worse, my depression's worse, my ADHD is worse. Um, and so it can be really helpful to take estrogen to treat this, right? Because let's talk about, the connection here was between estrogen, right? Like that seems to be the culprit in why these symptoms are occurring in all these different disorders, right? Why might that be? So estrogen actually modulates several neurotransmitters, all right? So it affects other chemicals. It affects dopamine, right? And we know dopamine is really important when we're talking about ADHD because that's, you've got attention is mediated by dopamine, executive functioning. Um, so a lot of folks might come in with worsening or pre-existing ADHD, um, and it's related to estrogen. So because of the dopamine issues, also acetylcholine um, is also modulated by estrogen, and that has effects on memory. I mean, we think about acetylcholinesterase inhibitors that are honestly not that effective for dementia, but like used for it, right? Serotonin is also affected by estrogen, so like there's where we're getting a lot of our mood and anxiety symptoms. And so, if estrogen is like helping us with our dopamine, serotonin, acetylcholine levels, and then those levels of estrogen are not consistent, then that means that these other related compounds are also not going to be consistent, and then they can lead to these symptoms. All right, so um, I know a lot of psychiatrists are afraid to give hormone replacement therapy. Um, I'm not one of them because I see the connection between estrogen and mood, anxiety, attention, ADHD. And I don't want to, if I'm treating that symptom, if I'm treating that disorder, then why am I sending them to somebody else that may not even want to put them on hormone replacement, right? And this could be, if you're in your menstruation years and you've got PMDD and you've got, your ADHD is like better controlled during half your cycle than your other half, taking birth control pills, right, could help with these issues. And we've talked about that for mood, and I've talked about how to do that. But you can do exactly the same thing when we're talking about ADHD, because we have very similar effects where we get worsening symptoms of ADHD during this time period. So this can be useful, right? And then we also have that menopause time period, that perimenopause. We talked about that when we talked about depression. Same thing, right? Because they both are kind of related to estrogen in the same way. Whereas estrogen levels are lower, the symptoms get worse. Okay. So this is why I think it's important. And then also to recognize this. You have a woman coming in, you recognize that she's going through perimenopause. Maybe no one else has picked up on it yet. She's not getting any treatment. And maybe her predominant symptoms are the mental health symptoms, and maybe her other doctors are not concerned about, or they're not making the connection with that. Maybe they're thinking about the hot flashes and the irregular periods and the weight gain and loss of libido and things like that, and they're thinking, okay, let's do some hormone replacement here. But what if she's not having those symptoms, or if those are tolerable but her predominant symptoms are more mental health related? They may be thinking that this is just a mental health disorder. They may not see that connection to this is actually related to the perimenopause itself, because it's not something that they're taught. And honestly, it's not something that we in mental health are taught. And that's why I think this episode is so important. So I think it's important to do hormone replacement therapy. And I mean, I talked about this before. The Women's Health Initiative came out like 2 decades ago, and for some reason scared everyone away from doing hormone replacement therapy. Before that, like all women going through perimenopause pretty much were doing it. And then there was this, increased risk that was found, but they were only looking at women over age 65 and had been taking it for long periods of time. And we know that this treatment is actually very safe for those under 65 that only use it for 5 years. And you typically only need it for around 5 years because um, your your perimenopause will end and you will not be experiencing this problem. So I think it's important to treat this, and it's actually quite safe to do so. But of course, there are contraindications that you need to be aware of. And also, as I said before, in this postmenopause time period, after we've kind of gotten through this rocky time, you you do have lower levels of estrogen, and your mood and stuff is going to level out hopefully at that time, but your ADHD symptoms might be worse. And so this is where I think about, maybe during that perimenopause, I'm going to lean more towards hormone replacement because of to kind of level off those like fluctuations. And then in the postmenopausal period, if we're having like issues with ADHD there, then maybe I'm thinking about starting ADHD medication. Maybe I'm thinking about increasing it, right? Because we don't want to be on this hormone replacement forever, right? it does have increased risk the longer you take it and the older you are, and it's not indicated to take it for like 20 or 30 years. So for that time period where you need it and when you're having maybe some other symptoms as well, that would be the best time to be using that. And then if we need something after that, then I'm and not that I wouldn't do ADHD medication during that time period as well. I might try one, and then if it doesn't work, try the other. Maybe this is not ADHD. Maybe it is a mood issue. Maybe we need to use an antidepressant. So you need to be thinking about all these different options. But I think people are not thinking about a lot of these options. And I think a lot of women, when they are a lot older, they come in and they have a lot of ADHD symptoms, and they may be looked at like, you don't have ADHD. You didn't never had it before. You didn't have it as a kid. Um, I can't give you this diagnosis. I can't give you this medication. But what if they're having these low levels of estrogen, and maybe they had mild ADHD that they were managing without really noticing it because it wasn't severe enough to really cause uh, dysfunction, right? But now that they're in this menopausal time period, it's become unmanageable because the symptoms have worsened. And while they may not have met criteria before, perhaps now they do, and perhaps giving them medication to treat ADHD, we're going to get some good effect there. So I would not, I feel like a lot of people they're very much like, oh, no, no, we have to follow the DSM exactly and all this stuff. And it's like, no, you got to personalize your treatment, and it's real hard to personalize if you're using the DSM. And the DSM is just so vague. Um, Once again, not a fan of like relying on that book for clinical treatment. So let's talk a little bit about hormone replacement. I've talked about this before. I'm going to talk about it again. Is related to, I mean, it's the same thing. I would use it the same way as I would talk about using it for menopause when I was talking about depression. But I just want to go over this again because it's really important. um, I think a lot of people kind of prescribe it without thinking about all the consequences, and I think a lot of people are afraid to prescribe it because they're worried about consequences that they don't really know what they are. And so I think it's important to know what you're looking for. All right. So these are the things to be on the lookout for and where we might be having issues when we're going to think about whether we want to use this medication or not. All right. So there is flexibility in how we dose estrogen and progesterone. All right. We can separate them. We can dose them separately. There are many different formulations they come in with different ratios, and it may benefit somebody to have maybe higher relative amounts of one versus another, depending on how their symptoms are going. Okay, so if one of these doesn't work, perhaps changing that up could be useful. Progesterone has to be given if you're giving someone estrogen, but only if they have a uterus. Okay, so that's because, right, estrogen increases the risk of uterine or endometrial cancer. Okay. If you don't have a uterus, you're not going to get uterine cancer. And so progesterone protects you, it decreases your risk of endometrial cancer. So if you give estrogen by itself, you've increased that risk. So we have to give progesterone. Now, if you don't have a uterus, we don't have to give you the progesterone because the whole reason it's given is really to protect you from the increased endometrial cancer risk that the estrogen does. All right. So um, keep that in mind because you can prescribe them separately. Now, if you do, I mean, there are different formulations of estrogen, but if we're treating mental health symptoms, we need to use the oral estrogen, not like the. I think the patch would probably be fine, but like not the vaginal one that's local, right? So we need something that's going to be systemic, and then so this estrogen helps with symptoms of menopause, increases the risk of endometrial cancer, and increases the risk of blood clots, right? So the blood clot risk is another thing we think about. Estrogen increases your risk of blood clots. So if you have an increased risk of blood clots, then you probably shouldn't be taking estrogen, or you should be seeing a specialist. And we'll talk about what those risks are in a second. All right. So progesterone, it decreases the risk of endometrial cancer, increases the risk of breast cancer after 5 years of taking it. Okay, that's why I said the 5 years. Um, Up to 5 years, your risk of breast cancer from taking progesterone is pretty minimal. And this is like during the perimenopause time period. So that's something to keep in mind of why we wouldn't want to use it too much longer. Um, it Progesterone helps with the symptoms of menopause as well. It helps with hot flashes, sleep, anxiety. So whereas I said that estrogen and progesterone, you don't have to give progesterone if the patient has had their uterus removed, that doesn't mean that you can't give it. Okay, so that progesterone could still help with hot flashes, sleep problems, anxiety, right? So it could still do that, but you don't have to do it. Also, if the patient has an IUD, that's progesterone. Okay, so if they have the IUD, you can give them just the oral estrogen so that you have both, right? You wouldn't want to give them progesterone in the pill because they're already getting it through the IUD. Okay, so an IUD is a way of giving them progesterone without giving it orally. All right, so progesterone also may not be well tolerated in some patients, and so you don't have to take it every day. You can just take progesterone 2 weeks every 3 months. All right, like this, this is something that like most folks are not aware of. If they get adverse effects from the progesterone, but they need to take it because we're trying to protect them from the endometrial cancer, you can take it for 2 weeks out of every 3 months, and we will get the protection that we need. Okay. So same thing with the estrogen. You don't have to take that every day either. All right. So because remember, we're not using this for birth. If we're using it for birth control, right, that's a different statement. Okay. But I'm talking about using it during perimenopause, um, and I'm talking about using it to treat mental health symptoms. If this is also a patient we're trying to prevent pregnancy with, we do need to take these every day. Okay. All right. So what are the contraindications to these medications? So progesterone, we have that cancer risk. So if they have a current or a history within 5 years of breast cancer, don't give them progesterone. If they have a history, I'm not going to give it at all. I'm going to defer this to somebody else. But that's what the somebody else has told me. History within 5 years is a contraindication. Okay. I would be too spooked to use it otherwise, but that's what I have been told. All right. So in estrogen, our main risk here is the coagulation, because remember the uterine cancer risk is not really a problem because we're taking it with progesterone. So that leaves coagulation is our risk. So our two risks are breast cancer and blood clots. All right, with using this. So if you have cardiovascular disease, a history of a DVT, deep vein thrombosis, PE, pulmonary embolism, right? So those are blood clots. If you've had blood clots in your legs and your lungs, poorly controlled high blood pressure, ischemic heart disease, that's coronary artery disease, heart attacks, things like that, history of strokes. This you're at risk. Okay, multiple risk factors for atherosclerotic disease. Um, if you're over 35, if you're a smoker, diabetes, hypertension, high cholesterol, complicated valvular heart disease. Okay. The CDC has an awesome chart that shows you like which of these conditions are acceptable to be able to prescribe these medications. And it's like if you're just a smoker, then that's not enough. But if you're over 35 and a smoker, then it's no. So some of this is like combined. If you have two of these, if you have diabetes and you're over 35, right? If you have high blood pressure and you're a smoker. So just one by itself, you can still probably prescribe it, but you know, most of the patients we're talking about are over 35. So if they're over 35 and they have any of this other stuff, then we probably can't prescribe this. So there's a lot of folks that do have this increased blood clot risk. a lot more than you might be thinking about. All right. So if they've had major surgery or a medical condition with prolonged immobilization, so right, you're not moving around, right? If you're not able to move around, that's increasing your risk. You need to be squeezing your muscles in your legs to move blood, so you're at increased risk of blood clots. If you have any kind of blood clot disorder, right? There's lots of them out there. Patients will know if they have one of these. Um, if you're within 21 days of giving birth, this is another risk. This is why we don't give birth control to women in this time period. And between 21 and 42 days, you have a relative risk. So after 42 days, we can give regular birth control. But before that, normally that's when we give the mini pill, right, which is just progesterone. Lupus increases your risk of blood clots. Migraine with aura. So migraines by themselves, no. Migraine with aura, yes. The risk is relatively low with the low doses of estrogen that we give. So um, that one I might ask somebody, do you think this is okay that we do this, or maybe defer it to an OB-GYN doctor. Um, so those are all things that increase blood clot risk. Cardiovascular disease, immobilization, not moving around. You had a major surgery. You have a blood clotting disorder. You recently gave birth. Lupus, migraine with aura. Those that's the list. Okay. Um, I've got a list here of indications that your estrogen is too high. So you're taking it, but your dose, you need a lower amount of estrogen. All right, and the acronym is ACHES, ACHES. A for abdominal pain, C for chest pain, H for headaches, E for eye problems, and S for swelling or severely painful legs. These are all signs that your estrogen, it needs to be lowered. All right. If these symptoms are severe, it could signal to stop medication. All right. We've got a few more contraindications. So if you've had a history of bariatric surgery, that can affect how you absorb. So if this is something you're taking orally and you had a history of bariatric surgery, weight loss surgery, that could be an issue. If you're taking this through your skin or something like that, or an IUD, not going to be an issue because we're skipping the gut. There are some drug interactions, some anticonvulsants, immunosuppressants, rifampin, uh, fosamprenavir. Um, these are not medications that are super commonly taken, so there aren't a lot of drug interactions. There are some drug interactions that can make them it less effective. I'm thinking of things like lamotrigine. Um, so that needs to be taken into consideration as well. Liver disease, so severe cirrhosis, liver tumors, those are contraindications to taking. But I mean, if you have a liver tumor or severe cirrhosis, are we really considering giving you hormone replacement? I don't know. But don't do it. Gallbladder disease. So this is another. If you have a current gallbladder disease or stones, so gallstones, if you've ever had them medically treated, if it's ever gotten to the point where they were medically treated, it's contraindication. All right. Diabetes with nephropathy, retinopathy, neuropathy. So like diabetes with like severe outcomes from diabetes, also contraindications. So there's quite a few contraindications. So a lot of things to keep in mind, but most of your patients are not going to have these, but you should know what they are if you're going to prescribe this medication. All right. So hope that makes sense, clears things up, and you're kind of thinking, okay, I know what the menstrual cycle is. I know how my ADHD symptoms get worse as we get into the luteal phase and during menstruation because estrogen levels are dropping, and um, during menopause, how we've got these like fluctuations, and that doing hormone replacement or birth control pills can help with this because it can help keep even these hormones out consistently throughout every day. And also, there might be the consideration to change the dose of the ADHD medications during certain times if you're noticing a correlation between a phase of life um, or during a phase of menses that seems to line up with, okay, that could be an explanation on why these symptoms happen at this time but not another time. All right. And so I think a lot of people, they don't think about that, and then they don't get the treatment. All right. So that is our discussion of how estrogen could affect ADHD. And I'm going to finish off with kind of some related stuff, like other issues in ADHD that might be challenging to treat. So like, during the menstrual cycle and perimenopause, these are challenging issues that I think a lot of people don't think about, where we need to maybe take a different approach to treating ADHD. And there's some other ones. All right. So executive functioning. So this is something to consider, where when we're looking at the symptoms of ADHD, inattention and you know hy- the hyperkinesis, like the moving around, hyperactive type of symptoms, right? So those inattention and hyperactive symptoms respond better to the medication. The executive functioning, so we're talking about organizing, planning, procrastinating. So the ability to be like, I'm going to like get things in order, I'm going to set goals, I'm going to achieve these, or I'm going to like not do that and procrastinate. These are symptoms of ADHD, or these are things that go along with ADHD, but they do not respond terribly well to medication, whereas inattention and hyperactivity are going to respond better. Okay. And so, maybe this is a primary problem. We've fixed this, but like, we're not organizing, we're not planning, we're procrastinating. Um, how might we tackle those symptoms, since the medications are not doing that well? Exercise can help. So physical exercise is a good one. Um, and then just like therapy. So like CBT, cognitive behavioral therapy, organizational training. So just kind of like teaching somebody how to organize. You know, and I talked about this early on in the ADHD series, and it's things like making lists and keeping a calendar and having a notebook with you, or putting notes in your phone, putting reminders in, putting alarms in, coming up with ways to like help you organize, setting time apart where I'm going to do this during this time and sticking to it, right? And then training someone to do this kind of stuff, right? There are some digital games that might help them with this. Non-stimulants, so stimulants being like Adderall and Concerta, um, and non-stimulants being like all the other ones we talked about kind of recently, the like the Strattera and the clonidine and medications like that. Those non-stimulants may be more helpful than the stimulants, but in combination, the two together, so maybe we're getting these executive functioning is challenging, and we're just taking a stimulant. Maybe we add a non-stimulant, see if that adds anything. All right. And then memantine, this is a medication which is sometimes used in Alzheimer's and dementia. There have been some studies that show that memantine, 5 to 10 milligrams twice a day, could help with some executive functioning. Also, there's some stuff out there to suggest it could be helpful with ASD, autism spectrum disorders, in helping with reading social cues. I mean, we don't have like super robust studies on that, but like when you've got no other options, memantine is pretty safe medication. It's a pretty low dose. Like, it might be worth trying it. All right. So I believe it's man, I forget the and something antagonist. I forget like how ketamine works. But let's go on to our next hard to treat issue. So executive functioning was the first. So autism, right? Autism spectrum disorders. When we have a lot of ADHD comorbidity. People with autism tend to either have ADHD, or their autism, um, it's just comorbid. The symptoms are similar, and so it looks like they have ADHD. This is harder to treat. Okay, so the response rate much lower, around 50% response rate. So not worth trying. Um, just not as effective as folks that don't have autism in their response to medication. They also have a tendency to have worse side effects from the meds. All right. So they don't respond as well to them and they have more side effects. All right. Stimulants can sometimes worsen symptoms of autism. It can make tics worse. We've talked about that. Stereopathy. So that's like kind of where you're doing these kind of repetitive motions and behaviors. Affect dysregulation. So that's like mood lability, your mood's changing a lot. So the medications could make autism, I talked about it could make some of it has the adverse effects, but it could actually worsen some of the symptoms of autism itself. Okay. Now, if you've got a higher functioning person with autism, they're more likely to respond to stimulants and non-stimulants. The lower functioning, they're going to have less responsiveness, which is, it's unfortunate because they're the ones that we really need a lot of help with. But the good news is if you have a high functioning autism patient, they may be a little bit more, they're going to be more likely to respond, probably less than if they didn't have autism, but more so than if they had a lower functioning autism. All right. And those lower functioning folks also more likely to have adverse effects as well. Like I said, the affect dysregulation, but also appetite issues, sleep issues as well could be worse. So if you're going to use medications, and we often do, you might want to titrate those, so increase the dose a little bit slower, and uh, try not to use the max dose in order to kind of mediate some of these issues. But and then just kind of be mindful that you're either not going to get as much as you want out of them, and maybe not anything at all. All right. And lastly, I'm going to talk about folks that have anxiety that's comorbid with um, autism. Okay, and I got two more after that. We're going to talk about mood stuff. So we'll talk about anxiety, depression, and bipolar disorder. So folks that have both ADHD and anxiety. So contrary to popular belief, stimulants actually usually will improve anxiety. So I think a lot of people will be like, "Oh, I'm not even going to give these because it'll make the anxiety worse." It actually can help. It actually is more likely to help than not. However, it can worsen. So um, try it, see what happens. If it gets worse, then change your plan. But like, don't not do it because you think it's going to get worse. It actually could improve the anxiety and the ADHD. All right. So atomoxetine or Strattera can actually help with both. Um, it doesn't work as well if the stimulants are tried first. So try the atomoxetine first. So if you've got a patient with ADHD and anxiety, you might want to try them on atomoxetine before you try them on a stimulant. Okay, so that might be your algorithm. Okay, let's go with the atomoxetine first, see if that works. Because I normally I would say, hey, stimulants work the best, but now we've got a little more confusing picture here. We've got a patient with like some anxiety issues as well, so maybe we want to go with atomoxetine first because there's some evidence to suggest if we don't do that, that it's more likely to work if they have never tried the stimulant. I don't know why that would be. This is just information I've gathered. Buspar, another option. Antipsychotics if it's severe. All right, so that's that's anxiety. So if we've got co-occurring depression, of course, SSRIs, bupropion. Bupropion's a good option because that treats both. TCAs, if it's an adult, can treat both, but I don't like the TCAs, the tricyclics. Bipolar disorder, we've talked about this. You want to stabilize the bipolar disorder on a mood stabilizer first, but then don't be afraid to treat the ADHD because there's huge comorbidities there. So put them on the mood stabilizer and then put them on an ADHD medication. So that wraps up not just our podcast today, not just hard to treat symptoms, but that wraps up ADHD in total. Talked about every med we could possibly talk about, and in every situation I could possibly talk about. And I hope, if you haven't listened to all the episodes in ADHD, go ahead and have a listen to those. Give me that rating. It would greatly help out to drive up the popularity of the show. It motivates me. Sometimes I think about quitting doing this. So if you don't want me to quit and you haven't rated it, um, I like my main driver. I'm not making money. I'm being motivated by the fact that I'm helping people. And when I see when people rate or they leave comments or they send me messages, it lets me know that people are listening and that they're enjoying what they're listening and that they want to hear more content. And that motivates me to put more content out there. If I don't receive that, my motivation is it's down. So um, please, if you can help me out, that would be great. And thank you for tuning into our ADHD series. What I'm going to probably do is I'm going to finish out the obesity series, and then I'm going to start a new topic after that. So thank you so much for joining me today, and I will see you next time.